Welcome to Health Stealth Radio, where we move away from the mundane to gather insights from the shadows of enterprise and patient cybersecurity. Yes, we surely believe that traditional themes like endpoint software and zero trust are critical, but given massive advances in AI, remote and wearable device hacking, and data hostage negotiators, there's a much darker side to cybersecurity, and not everyone is quite willing to talk about it in public. Health Stealth Radio will thrive on these topics and encourage fireside spats to debate them. Here's your host, Frank Cutitta.
I'd like to thank you for joining us today. This is Frank Cutitta. I would like to welcome you to Health Stealth Radio. Today we have the honor of having Dr. Levine with us, who is, I'd say, to put it mildly, is a pioneer in the broader hospital at home area, and now is expanding into another test, which I thought our audience would be interested in from both a care delivery point of view, and everything we do at Chime has some touch related to this thing called technology. So without further ado, I'll introduce Dr. Levine here and let him tell you a little bit about his current position today in the life of. And we like to, at this start of our interviews, have our guests say something fun that they've done this summer.
Well, thanks, Frank. Thanks for having me. It's great to be with you all. Goodness, something fun I've done this summer. I think one of the best things is I've gotten to eat blackberries out of my own garden this summer.
There you go. Nice.
So I've been waiting 2 years for blackberries, and we finally got them this summer. So that's been good. Wow. And the birds didn't get them first, so that was nice.
That's a new one. That's great. That's great. So again, international pioneer in the broader hospital at home movement. Now we're talking about a skilled nursing facility. So I'm just curious about how we got to where you were, and this is obviously a subset of high acuity care at home, but it's different. It's different. There's a lot of aspects to it that I'm sure you're testing to see if it works. So tell me a little bit about how you made the jump from the general to the more specific.
Yeah, absolutely. I mean, as you know, all of my research and a lot of my efforts are focused on advanced home-based care and trying to change the paradigm that, we need to deliver care in a facility to we can deliver care at a patient's home. And a lot of things happen, unfortunately, in rehab facilities. And so this has been a very natural area for me to want to focus on. We've, have definitely started in hospitals where a lot of care happens, right? Almost a third of care, at least the cost of care, happens in hospitals. A whole bunch of that care also happens in post-acute care facilities. And so it was just a kind of a natural area for me to say, hey, you know what? If we can do things like high acuity care, hospital level care at home, we should probably be able to do rehab level care at home too. But it's an empiric question. You got to prove it. And you got to see, is it cost effective? Is it high quality? Is it safe? Do patients prefer it? And so actually back in 2019, we did a pilot of rehab at home just before the pandemic. Just a tiny pilot. We're able to show that, yes, we can do it. Yes, we can collect the data for it. We can even randomize patients to either arm. And the very preliminary, very tiny data looked good. It looked like it was worth doing again. And so I have, for almost the past 5 years, been trying to relaunch that effort in order to test this in a much bigger way. And so we're really have an amazing opportunity, thanks to the Executive Office of Health and Human Services in Massachusetts, to run this trial, to test this trial and to see, is this a care model that we should be offering around the country?
So the state was the inflection point that they bought into it. So now we could actually do what we were talking about.
You got it. They offered this opportunity up as an RFP. We were able to compete successfully for it and are now really excited to be carrying it out.
So as a guy who spent a fair amount of time in a rehab facility that you know and love very well, and I do too, the model is somewhat different just in terms of the environment, the ergonomics. I mean, are we going to bring parallel bars into somebody's home? I mean, what do you, what's I'm just thinking about things that I had in the post-acute care that were large. And having said that, I was amazed during my experience of how little technology was really involved in my rehab. There was really a lot of really basic stuff. I thought I'd have like the Charlestown facility where I had diodes and everything hooked to me and I was doing muscle stimulation, when in fact it was mostly mind games that were really easy to play with me at that point.
You're right, Frank. There are adjustments that need to be made when we deliver this kind of care in a patient's home. My hypothesis, and I think the data are gonna tell us whether we're right or wrong, is that we can make those adjustments, right? We can change the kinds of exercises that patients need to do. We can bring in portable versions of some things. I don't know about the parallel bars, but
I'm exaggerating.
We can bring in some of the things that patients need and do those things right in their home with them. And we actually have experience during the pilot, for example, of avatar-based 3D camera physical therapy sessions.
Wow. Interesting.
And we're this time around going a little lower tech, actually. And I think because of the tech stack that we're using, we're actually going to get patients more exercise at home than they would have gotten had they gone to the traditional rehab facility.
I can believe that. One of the most technology-driven things that I had during my rehab was cornhole. So, it was literally a major part of that part of what I was doing. So I just, like I said, I looked at all the fancy stuff at Charlestown, and then I say, well, I'm playing cornhole in Cambridge, which worked very well. So I think you're right that there are things that are more home type exercise, if you will, that yoga, stuff like that you could do that works very well. So the story is the workforce story. It's all over the place. I mean, and the nursing situation, I get to see bits and pieces of that in my work at Chime and what I did at HIMSS. So how about the staffing on this? I mean, are nurses like, wow, I'm glad to get out of the bricks and mortar and go into facilities like this, like we've seen with some of the hospital at home stuff with like Best Buy people going in that used to be nurses and saying, wow, I'm leaving Best Buy because I didn't want to be in nursing and now I'm going into people's homes.
Yeah, so you definitely have that right. There is a big nursing and in general healthcare worker staffing crisis. We actually think that we're going to be helping that with this rehab at home model. And the reason is that a lot of our staffing scenarios ensure that we are getting folks to practice or to perform at the very top of their training. And so, for example, we have our physicians who absolutely, I think it's paramount that they go to the home. They do a home visit. There's a lot to be gained when you go to a patient's home and a lot of help that you can provide when you go to a patient's home. But once they go to the patient's home, they're then going to use technology to stay connected to the patient after that, whether those are video visits, whether that's monitoring data that they're going to gather. A lot of opportunity then for that physician to be practicing elsewhere, to be doing other things while they're overseeing this rehab level care. That's not something you can usually do in a traditional rehab facility. We're doing the very same thing with our nursing colleagues, and we're moving folks to the very, very top of their training so that they can, using technology, can oversee the care that's then being delivered by folks with slightly less training. And I think that what that does is that broadens and diversifies the workforce, right? So now you don't need to find X FTE of physicians and Y FTE of nurses. Maybe you have to find a few more certified nursing assistants Maybe you have to find a few more home health aides. But those folks are much more facilely trained. There's a bigger pool of them. They are less in demand than a nurse or a physician. Not to say they're not in demand, and they are, but they're less in demand than a nurse or physician. And so we think that our staffing model actually is part of the answer to the staffing crisis.
I agree with you. And I think the other part that you mentioned about getting into the home, we've seen this. I remember during the early days when I was doing the hospital home summit and building the blueprint for that, that it was the first time physicians really got to see social determinants of health. They walked into the place, opened up the closet, and said they've got beef jerky and cheese. It's here, and that's not what they told me they had when they were in the ward. So I think that part of it is great. You alluded to the fact of the technology, which is a lot of the audience that's sitting here listening to us, both of us today. I'm assuming that that's no different than when you would deploy a traditional hospital at home, if there's such a thing as traditional hospital at home, in the evolution that it's had.
Yeah, it is a slightly different tech stack. We don't need the same high acuity monitoring that we do in home hospital because these are not highly acutely ill patients anymore, right? They're post-acute. And we also need a different kind of usability. I think this is really important for all the tech listeners right now, is that, for example, one of the critical aspects for usability is that patients will actually wear or interact with this technology for more than a couple days, which is, your home hospital stay, you don't need that super fine usability profile. For rehab at home, we're talking about 15, 20-day lengths of stay. You got to be able to wear that watch, or you got to be able to have that patch on for that long time. And let me tell you, a lot of those technologies don't work for that long. Patients take them off. Patients refuse to use them. And so really a big focus of ours has been to try to identify that tech stack. I'm not saying we have it right for this trial, but it's part of the learning where we're hoping that, folks in the future also can focus on something that is usable and for a medium term, I would say, that's still able to gather some pretty important data.
Obviously, the conditions are different for high acuity hospital at home versus the SNF. What's the selection process? How do you pick the best? And the it's always there. The B question is, what are the equity issues? I mean, is this something that low income families can avail themselves to as much as people that are of means?
Yeah, absolutely. Great questions. I think in terms of the selection process, for the study that we're currently embarking on, we have very standard set of inclusion exclusion criteria. We have a team of research coordinators who are amazing. We have a team of who we call geriatric liaisons in the hospital, there to assess a patient, explain what rehab at home is to them, explain what kind of technology they may be using in the home, and then enroll them, and for our purposes, actually randomize them, right? It's a randomized controlled trial. So half of them will go to the regular skilled nursing facility, the other half will go home.
Okay.
And I think for equity purposes, we have worked really hard to build a system that is highly equitable in terms of the care delivery. And so, patients can be of whatever financial means. They can live alone or live with family. They can have various different kinds of social determinants of health. We can bring food to a patient's home. We bring aides to a patient's home 24/7. A whole set of different opportunities to essentially deliver equitable care.
So the elephant in the room has always been this thing called reimbursement. Is the reimbursement model in terms of the hospital at home waiver that's being discussed constantly in Washington and other places? Is this fall under a different kind of payer model?
You know, I don't know that it falls under a different payer model. It doesn't fall under the acute hospital care at home waiver for sure.
It doesn't. Okay.
No. But that is a perfect model for what this could become. And so, we're actually hoping to follow a very similar path that we did for home hospital, which was, we did, as much research as we could, other folks as well. CMS was able to analyze that research, was able to see kind of the positives there as well as the negatives. And they moved forward with a waiver program. And as you and I both know, and I'm sure many listeners do, we'll see if we can get that extended before December 2024 runs out this year.
Yeah. How's it looking, by the way?
I don't have a crystal ball.
Not a gambling man.
I am feeling positive, though. I'll just say that.
Yeah, okay.
We've gotten past several of the important committees in Congress, and it's a bipartisan issue that the CBO has scored budget neutral. This is something that, without the Mishugas of politics, should be a no-brainer. Right. But we'll see. It's hard.
So let me look at the continuum of care. So if I were in as a high acuity hospital at home patient and I got through the high acuity part of it and got to the SNF part, is that a different program? So it can't be bundled under the waiver once it starts the rehab process. Is that what you're saying?
It cannot. Yeah.
Okay.
The waiver is specifically for that acute care DRG, the diagnosis related. Okay. So the hospital is going to get paid for the acute care. In the future, hopefully we can have a skilled nursing facility care at home waiver. I don't even know what that acronym sounds like.
Okay, need to buy a vowel. Yeah,
something like SNFCA maybe. But we could get that waiver program up and running, and then SNFs and hospitals and anyone eligible for that kind of waiver
keep on going.
Could provide that episode after that, because trust me, our home hospital team at MGB has asked, well, could we transfer to the rehab at home study? And right now the answer is no. Right, we're keeping it very clean. We're keeping it just like regular hospital care to regular rehab care. But that is definitely the future. We absolutely need a reimbursement mechanism. And that's why EOHHS in Massachusetts is very kindly funding all of that care right now as part of the study.
That's fantastic. So as it starts rolling out into other providers, is there any pushback anywhere? Or there's like surprises where people say, "Oh, I don't know," or and always the other question is, and you're the master given your pilot program, which is legendary. What about the CFOs? I mean, how are they feeling about things like this, where it's I guess it's still getting the revenue in some way. It's just coming from home, right?
Yeah. We haven't had a ton of pushback, I'll be honest. We haven't really had a ton of pushback on this, but it's very early days too, right? I'll be the first person to push back on this if our trial doesn't come out with positive outcomes. That's the beauty of research, right? But I'll tell you that the CFOs are very excited about this, particularly in the hospital side, but also in the skilled nursing side. So, the CFOs in the hospital side look at this and say, oh, wow, this is going to help me offload all of my patients who are waiting and waiting and waiting for a rehab bed. And as you may know, there are hundreds of patients in the state of Massachusetts alone just sitting in hospital waiting for a rehab bed. It is a big problem. I hear that
all the time.
Right? And that then causes hundreds of patients waiting for beds in the emergency department to get in. Right? If you can't get out the door, people are going to be waiting.
And everybody's at risk of getting some kind of hospital-acquired ailment, which is what hospital at home was always first in line to prevent.
Exactly. And so the hope is that from a CFO standpoint, this is something that can improve throughput in the hospital, which is a good thing for everybody, not just for the bottom line, but also for the patients. And then the skilled nursing facility CFO looks at this as a new opportunity, right? This is a new way to deliver the high quality rehab care that they're used to delivering, but outside of their traditional four walls. And so should there be a waiver in the future for this, this would be something that I think high performing skilled nursing facilities would be really excited about. They'd say, absolutely, send us your patient, and the patients that qualify, we're going to deliver them the care at home.
Fantastic.
And so I think that is a potential future arrangement.
One last question. I mean, you're always ahead of the game on this. I mean, you've moved into this one after being in the general hospital at home. Is there another one out there that you're just thinking of, that this is something else that could be done at the home that we're just not quite doing it? I know you want to take it one bite at a time, but I know I've known you long enough that you just don't stop thinking about the what's next.
It's a great question. One of my favorite areas right now that we're working slowly on, but hopefully we'll be able to attract a bunch more funding in the near future, that I think will completely revolutionize the way we're delivering care in the home. And don't laugh, Frank, it is with medical drones. And so we have an entire kind of setup and system to provide emergent care via drone, urgent care via drone in the home, chronic primary care via drone, and then acute care as well via drone. I think it will absolutely. So
what did now you're teasing me? You're teasing me, just like you did with the extended reality. I think of Cedars-Sinai and what they're doing there, which is just is amazing. So what does the drone deliver other than the obvious box of something?
Yeah, well, there's the obvious one, right? So there's the emergency care version, right? And this is actually already happening in Sweden. If you call 911 in Stockholm and you're having a cardiac arrest and there's a bystander there, they will deliver you an automated external defibrillator by drone. They have beautiful paper published on that.
That's amazing.
And they will speed up time to shock by over 3 minutes by doing that, right? So that's just a very simple example of what we can and should be doing.
That makes sense.
But then there's also these use cases, right, that will completely revolutionize the logistics and how facile it is to deliver some of this care. So I can give you an example. If there's a patient all the way downtown one way, an hour worth of traffic to get there, and all of a sudden the nurse says, oh my goodness, the urine culture just came back and it's resistant to the antibiotic I have in my hand. I shouldn't bother giving it to the patient. Well, just got to snap your fingers. 5 minutes later, 10 minutes, even 15 minutes later, a third of the time, drone shows up, lowers down the antibiotic, picks up the blood cultures that the nurse just drew, and takes them back to the lab. And you can imagine there's all sorts of urgent and chronic and acute care scenarios that you could solve for very, very easily.
I love that.
If you had a medical drone system.
I love that. I'd like to work together on an article on that. So this is fantastic. It's always great talking with you. I always get invigorated. It's great working with you, and appreciate it on behalf of Chime and Health Stealth Radio. Appreciate the time that you always give us, and hope we can work with you more on the actually hospital at home and maybe SNF at home series that we're doing at Chime here as part of my content group. So thank you as always. Love you.
Thank you, Frank. Great to talk.
Take care now. Bye-bye.
Thank you for joining us today in the shadows for this episode of Health Stealth Radio with Frank Cutitta. If you like the program, please be sure to share your comments on our social media sites, or feel free to contact us with suggestions for new and stealthy show themes. We look forward to welcoming you again for our next broadcast. In the meantime, stay safe out there.